Welcome to today's webinar, Embracing Genomics in Cancer Care, focusing on the individual patient. My name is Sarah Tarani, and I am the Program Coordinator at Triage Cancer. I'd like to take a moment to recognize our generous sponsors of the 2007 Triage Cancer webinar series. Without the support of Takeda Oncology, Genomic Health, and Ignita, we would not be able to host these webinars for free. For those of you who aren't aware, Triage Cancer is a national nonprofit organization that provides information and resources on cancer survivorship issues. We also host and participate in educational events all over the country for patients, survivors, caregivers, advocates, and healthcare professionals. We host a series of conferences each year and cover a variety of cancer survivorship topics. We just planned our 2018 schedule and we'll be in Ypsilanti, Michigan. I love that name. Reno, Nevada, and Lewiston, Maine next year. Travel assistance is available for patients and survivors to attend these events. And as most of you know, we have monthly webinars, and the next regularly scheduled one is on October 18th, and that is going to be about choosing wisely how to pick an insurance plan. Make sure you register for that. We've also recently rolled out a new program, the Insurance and Finance Intensive. This is a comprehensive certificate program for oncology healthcare professionals and advocates on health and disability insurance and finances. We're hosting the very first intensive in just a couple of weeks in Orange, California on October 17th. Registration is still open for that, so please register if you'd like to attend. And if you'd like to have an intensive in your area, please email us at info@triagecancer.org. We'd be happy to roll into your town and do it. We also host a Speakers Bureau of experts in all types of cancer survivorship issues available to organizations putting together an educational event. You can read our speakers' bios and request a speaker on our website. Triage Cancer also provides state-specific and national resources on our website. Excuse me. And because where you live can impact your protections you have access to, we have a chart with state laws on employment, disability, health insurance, and health insurance related issues. So that is very helpful to you. And we also have quick guides on a variety of topics, such as employment, finances, privacy, clinical trials, chemo brain. They are all designed to be a snapshot on a particular topic. You can download those on our website. And we also have a relatively new resource called Cancer Finances, and which you find at cancerfinances.org. It's an online tool designed to be a comprehensive source of reliable information for individuals trying to navigate finances after a cancer diagnosis. After answering a few simple questions pertaining to the individual situation, individuals with any type of cancer will be presented with a personalized, actionable information plan. Currently, there are modules for health insurance, disability insurance, and financial assistance resources. We'll be adding new modules on education and employment later in the year. And lastly, we have an educational blog and e-newsletter where we post late-breaking news that impacts the cancer community, as well as substantive information about cancer survivorship issues and educational events and resources in the cancer community. Our October newsletter went out today, so hopefully you received it. Now, without further ado, I'd like to introduce our speaker for today, Dr. Christy Russell. Dr. Russell received her medical degree from the Medical College of Pennsylvania in Philadelphia. She completed a residency in internal medicine at the Good Samaritan Medical Center and Phoenix Veteran Hospital in Phoenix, Arizona, and a fellowship in hematology oncology at the Los Angeles County University of Southern California Medical Center in Los Angeles. She joined the USC Department of Medicine faculty in 1986 and worked there for 31 years. and she joined Genomic Health as the Senior Director of U.S. Medical Affairs in January 2017. There is so much more I could say, but we only have an hour. So without that, I'd like to hand it over to Dr. Russell.
Thank you, and hello, everybody. So I'm trying to get control of, there we go. So I'm going to talk today, sorry about that, I'm going to talk today about, I'm just having trouble controlling these slides. That's why I'm a doctor and not a slide advancer, I guess. So we're going to talk today about genomics in cancer care and how an individual patient can benefit from genomics related to her cancer. Oh my goodness, I'm going backwards and forwards. My arrows apparently don't feel like they need to work correctly right now, so I'll just do it this way. All right, so I think I've got it under control. So what are we going to talk about today? We're going to talk about the difference between genetics and genomics, and what the difference is when you have someone who's thinking about those two things so that we can all help define what they mean. We'll talk a little bit about how oncology care has changed over the last 40 years. What kind of progress have we made? How does genomic information help patients with patient care? And how do all of us talk with patients to help understand these very complex ideas and thoughts? For patients with early cancer, and I'm a breast cancer specialist, what can we offer to them if they have early stage disease? How can genomics help in late stage disease? And if anybody has questions at the end, please feel free to go ahead and write them down now so you can put them in, or put them in whenever you want to put them in. We're going to address questions at the end. All right, so how do we define the difference between genetics and genomics? So genetics to me is something you're born with. This is what's in your normal genes, in normal cells in your body. So when I think about genetics, it's helped to predict the risk of developing a disease or cancer. So BRCA1 and 2 are very well known. That's BRCA is so complicated. It stands for breast cancer 1 and 2, and they can predict increased risk of breast, ovarian cancer, and actually multiple other cancers as well. Like men with BRCA mutation may have increased risk of pancreas cancer or prostate cancer. There's also a gene you can be born with, which is called the APC gene, which gives you a markedly increased risk of developing colon polyps and colon cancer. Sometimes the genetics can be used to locate targets for intervention. And generally, when we talk about genetics, we're talking about mutations in what are considered to be normal genes. In terms of genomics is more like testing the genes on the cancer as opposed to the person. Genomics could be used to help us understand early and accurate diagnoses of cancers. It can help greater individualize how we think about treatment when we're considering treatment, like we're looking at the genes of the cancer to help define specific therapy. When we talk about targeted therapy or personalized therapy, this is all based on genomics of the cancer itself, not genetics of the human, or it's to me seed and soil a little bit. We're also beginning to use genomics to help put people into specific clinical trials where they have a greater likelihood of benefiting from new therapies. It allows us to have more rational new drug discovery, and drug development can be faster if we don't neutralize people in the clinical trials that don't have a specific genetic abnormality in their cancers with a targeted therapy that will only impact on those kind of cancers or that gene abnormality. All right, so the other concept I want to talk about is prognosis and prediction. Prognosis to me means, like in a breast cancer world, I've been diagnosed with my breast cancer, I've had my surgery or my lump removed, maybe I've had radiation. What is the likelihood that my cancer is going to come back? And are there factors within my cancer, size of the cancer or grade of it, how undifferentiated it is or it's well differentiated? Estrogen receptor could be prognostic. People with breast cancer that have a positive estrogen receptor have a better outcome than those who don't have that receptor. So this is, you get your baseline treatment, and based on that treatment, what is my outcome expected to be? That's prognosis. Prediction is, what is the likelihood a specific therapy is going to work for me? And prediction's a positive thing. So that you can, if you say, for example, a breast cancer that is a certain size and a certain aggressiveness, but it has an estrogen receptor, that estrogen receptor will predict for benefit from a hormone blocker. There's a gene called HER2, and if HER2 is abnormal, that would predict for benefit from Herceptin. So to me, prediction means you've got your baseline therapy. Is there an additional therapy that can positively influence your outcome? That's how I view prediction. These are slow for slide advancers. Okay, so what has happened with the oncology practice over the last 40 years? This is just major milestones, and they just are things that have happened within oncology, not all necessarily related to our topic today, but for example, in breast cancer, tamoxifen was approved in 1978. Tamoxifen is probably a drug that's had the greatest impact on survival and curability of breast cancer since it started to be used more routinely. In 1990, the Human Genome Project began, which has had an enormous effect on our ability to understand genomics as well as genetics. In 2003, so 13 years after we started the Human Genome Project, it's completed after mapping 3 billion DNA letters in the human genome. In 2016, Vice President Biden started the Cancer Moonshot with substantial funding from the U.S. government. All kinds of things have been going on in major cancer milestones. And the bottom line is that the death rate from cancers in general continues to slowly decrease over time. But for any individual who's facing advanced cancer, that's not a comforting piece of knowledge. It comes back to what's happening with me. So it's just kind of a funny slide. Like you see on the upper left-hand side, it's actually a fire engine, I believe, run by horses on the right-hand side of the car. And Henry Ford said, if I had asked people what they really wanted, they would have said, I want faster horses, and that we begin to limit ourselves in future thinking by what we know right now, and that we need to, especially in cancer therapy, to move it along, have much more strategic future knowledge, but we have to have the tools in order to move those things along. So genomics, we're going to talk about early stage disease and answering difficult questions. So when we think about lung cancer, people have lung cancer, they're diagnosed, they get a surgery or don't, they get radiation or don't, but everybody's treated the same. And you would have an occasional responder to some sort of chemotherapy, for example, but we didn't separate people out by specific kinds of therapies. The same with colon cancer. If your cancer was so big, if you had so many lymph nodes involved, you were offered chemotherapy after your surgery had been completed. There are now different ways of looking at all these cancers. One is invasive breast cancer. These are assays, gene assays that are done on the cancer cells themselves. There are 5 that are on the market right now for a woman with early breast cancer, where we will send her cancer off after it's diagnosed to do gene testing to help understand her prognosis and occasionally to understand whether or not she needs chemotherapy. In colon cancer, there are 4 that are on the market that are used for someone who's had their colon cancer removed to try to understand what their risk is that the cancer could come back again. And in prostate cancer, these are assays for men who've been diagnosed with prostate cancer to help decide whether they even need to have their prostate removed, or will the genes from the prostate cancer tell us that it's just going to sit in the prostate but not spread anywhere. So we are now beginning to use the cancer itself and the genomics of the cancer to help move us along a little bit. So this is a little bit more commercialized, but it has to do with Genomic Health. That is the company I'm currently working on. This is one of the companies at the forefront for personalized cancer medicine. So, for example, we have a test used for women with early breast cancer. The test is done on the cancer once it's removed, and the question we're trying to answer is, will I need chemotherapy? Will I benefit from chemotherapy? For men and women with stage 2 or 3 colon cancer, the gene test will suggest how aggressive the cancer is and tell you your risk that the cancer is going to come back again, so you can help decide upon chemotherapy. In DCIS, or non-invasive breast cancer, we have a gene test that predicts, that tells you how much benefit you could expect to receive from radiation after a lumpectomy. In prostate cancer, again, do I need to have surgery, or could we just watch and wait because my cancer's genomics are telling me this is never going to spread? And we have some increasing gene tests we're doing for people with late-stage cancer to understand specific therapies. All right, so when I talk about Archetype DX for invasive breast cancer, the question we're trying to answer is who will benefit from chemotherapy. So why is this important? Well, up until the last 10 years or so, we would say that if you had a cancer that was over a centimeter, that regardless of whether lymph nodes were involved or not, regardless of how the other testing was done on the cancer, you need to receive chemotherapy. And it was one of those kind of bucket decisions that we just couldn't personalize things better for individual cancers. And we couldn't really understand, of all this therapy we're using, who will and will not benefit from those treatments. So the question is, if you have an estrogen receptor positive breast cancer, if it's dependent upon estrogen to grow, we standardly will use an estrogen blocker. And there's lots of estrogen blockers we use. But how about chemotherapy? Do I really need to use chemotherapy? And we can use this genomic test called Archetype DX to try to understand whether you will benefit from chemotherapy or not. So I'm going to dive a little bit into this one specific test. This is a test that's been on the market since 2004, and to me, as a breast cancer oncologist, revolutionized the ability to make decisions with my patients around the issue of chemotherapy. So it's called a 21-gene score. There are 5 reference genes, so we get the tumor and we test for how these 5 reference genes are functioning. And if we can test that they're functioning at all and our test comes out positive, we see that they're there and they're functioning, then we know that we can believe the outcome of the other 16 breast cancer-related genes. So the breast cancer-related genes are broken down into different groups. I don't think that matters, but we're using these genes to not only tell us, if I take my estrogen blocker, what is my still ongoing risk of developing metastatic cancer? And if I just take the estrogen blocker, if my risk is high enough, will I actually benefit from taking chemotherapy? So there was this large study that was done that looked at women in the 1980s. There were 4,000 women in this study, and half of these women, after their lumpectomy and their lymph nodes being removed, half of these women got no more therapy. If they had a lumpectomy, they got radiation therapy. If they had a mastectomy, they got no more therapy. And half of the women, after their appropriate surgery, received 5 years of tamoxifen. And we had the blocks, or the tumors, from the women in this trial, and we showed that we could do this genomic testing on their cancers. And so what you see here is a curve of the outcomes of the 21 gene testing, and that outcome is called a recurrence score. So the score is just a number, it's not a risk. It's a number that gets plotted on this graph, and it tells us if the woman receives her 5 years of her estrogen blocker, in this example it was tamoxifen, what is her leftover risk that she could develop metastases. So for example, if someone had a recurrence score of 15, you would come up here and you go, wow, if you took 5 years of tamoxifen, you have about an 8% leftover risk that you're going to develop metastases sometime in the next 10 years. If you have a recurrence score, if your genes are telling us your recurrence score is 30, then you have more like a 20% chance over the next 10 years. So that's prognosis. This score is telling us, if I take my standard therapy, what is my leftover risk that my cancer could come back again? So we have kind of two examples of women that we've done these tests on. These are real women, and on the bottom there are two different well-known breast medical oncologists in this country who submitted the tumors in these cases. The first is a 36-year-old woman with a small cancer. It's 1.1 centimeters, so it's a little less than a half of an inch. She's young, obviously, premenopausal. Her tumor size, as stated, is 1.1 centimeter, and the cancer is strongly showing it's very dependent upon estrogen and progesterone to grow. So the estrogen receptor and progesterone receptor are both positive in the cancer cells. The gene called HER2/neu is normal, or what we would call negative. It's got a histologic grade of 6 out of 9, which means under the microscope it just looks like a kind of standard cancer. It's not too aggressive, it's not too benign looking, and her lymph nodes are negative. Beside her is a 39-year-old woman with a 2-centimeter cancer, so it's bigger. Again, her estrogen receptor is positive, but now her progesterone receptor on the cancer is negative. That usually suggests it's going to be a little bit more aggressive of a cancer. The grade is sort of in the middle of the road as well. So women similar age, similar size cancers, but the one who we would have predicted would have had a better outcome is the one on the left, whose recurrence score is 36, and the one on the right who lost the progesterone receptor in her cancer that I would have expected to be a much more aggressive cancer is on the right-hand side. So the patient on the left, her recurrence score, so those 21 genes are telling us her recurrence score is 36, and that comes up to about a 22% chance that within the next 10 years she's going to develop metastases. And on the right is a gal whose recurrence score is 8, and that's given her about a 7% chance of developing distant metastases within the next 10 years. So what do we do with that information? I'll go backwards a little bit. Oh, and I'm not going backwards. I'm going forwards. Okay, let me try. I'm not playing this advanced slide game very well. The other thing we've learned from here is that women who are sitting in this really low range, actually this low range under 18, or a low range under 31 don't seem to get any benefit from chemotherapy. And the only patients who truly seem to get benefit from chemotherapy are patients whose recurrence score is over 31. And so now, not only do we know her leftover risk, but now we know whether to offer chemotherapy or not, and we can predict how much benefit she'll get from that chemotherapy. So women with that knowledge can do whatever they want with it. They could go, I don't care, I have a very low risk, I want chemotherapy anyway, and that's fine. You could say, well, your risk over the next 10 years of developing metastases is 7%. If you take chemotherapy, it'll be 7%. So you decide whether you still want to take chemotherapy. On the other hand, women with really high score seem to get a lot of benefit from chemotherapy, it reduces their risk almost 70% of whatever their risk is. So this gal with about a 22% risk on the left, if she got chemotherapy, it would probably reduce her risk to about 8 to 10%, almost ending up to be the same risk as the gal on the right who does not get chemotherapy, all based on the genomics. Even though the women are similar age, the one on the right has a larger tumor. It looks more aggressive under the microscope. So genomics has had a massive impact on decision-making for chemotherapy in this group of women. So the next one I was going to talk about is the colon cancer. If I have my colon cancer and it's removed, do I need chemotherapy for that? And so the challenge is 75 to 80% of people with stage 2 colon cancer are cured with surgery alone, and the absolute benefit of chemotherapy is pretty small. And so you want to have a fairly high risk to get enough benefit from chemotherapy to think that that's something that is worth doing. And the chemotherapy for colon cancer in many ways tends to be much more toxic than many of the chemotherapies we use for breast cancer. So right now, when doctors decide who to give chemotherapy to for colon cancer, they're really looking at pathologic factors. How big is the cancer? How aggressive did it pass through the colon wall? Those sorts of things. But they also decide based on how old the patient is. Do they think they could tolerate such a toxic chemotherapy? And now is the role of genomics. Can we do better to help understand what the real risk is, not just these tumor size issues, which are very poorly defined and are not actually all that prognostic. So we have a 12-gene colon cancer score. Again, on the bottom are the 5 reference genes that have to be testable for us to believe the genes up above. And then up above, you can see there are 7 cancer-related genes. And so what this is showing is that on that green line in the middle, the higher the recurrence score, the higher the risk that you're going to develop metastases. And so what people are doing are using this to make decisions about giving chemotherapy or not. At least it's giving you risks of developing metastatic cancer so you can decide with your doctor whether you want to receive chemotherapy or not. Newest to our portfolio is this Archetype DX for prostate cancer. And one of the issues has been is many men develop prostate cancer. It tends to be a silent cancer for many men, but it is a very common cancer as well. It gets diagnosed in over 200,000 men per year. Sometimes up to 250,000 men per year, depending upon how much PSA screening is being done. And so when the prostate cancer is diagnosed and a biopsy is done of the prostate and we see that there's a cancer there, the question is what to do next. And so there are options of what to do next. One is, should I have surgery to remove my prostate? There are different kinds of surgery depending upon the training of the urologist who does this. Can I avoid surgery and just go right to kind of localized therapies, just take a hormone blocker? Should I just have my prostate radiated? And there are different forms of radiation therapy, or active surveillance, which means I'll just be watched. I'll be watched with intermittent PSA blood tests, physical examinations, and intermittent biopsies done of the prostate. And I think the reason why this is an appropriate question is men with prostate cancer tend to be older. Certainly they tend to be older than women with breast cancer. And so the issue of surgery and comorbidities or other medical problems comes on board. And both surgery and radiation can give you a fairly high rate of complications: incontinence of urine, erectile dysfunction, which can be permanent, so that there are physical issues that occur as well in the treatment of prostate cancer. So for a long time, we've had these issues around PSA, the blood test for prostate cancer, not only to diagnose it, but to try to understand how aggressive that cancer might be. There's still recommendations around whether to even test men for PSA on a yearly basis, the way we test mammography for breast cancer. And there are people that are on both sides of this argument continuously. So here's the conundrum. When men get a prostate biopsy, what they do is they do multiple biopsies, and then they look at the grade. So they look at the grade. What is of these biopsies? The grade is on a 1 to 5 scale, and if the biopsy is grade 3/3, what that means is the grade 3 seems in that core to be the highest grade, and it represents the majority of the grades throughout all the other biopsies as well. So there's a way that they do this grading system. This patient tends to have a grade 3+4. The majority of the tumors being biopsied are grade 3, but the highest grade is being grade 4, so they add those two up and it's a 7. So for men with prostate cancer, over-treatment's a real problem, I think much more than in breast cancer. And the morbidity of the treatments is much worse long-term for men with prostate cancer. It's expensive. It's projected that we will spend $12 billion a year annually by the year 2020 in the treatment of prostate cancer. So all these treatments have short-term risks and they have long-term risks. And the long-term risk, again, is urinary incontinence or erectile dysfunction. And most prostate cancer tends to grow really slowly. So most men will, if you just watch the prostate cancer, will not die from it. They will die with it. So the question is, will the treatment help me if I have my prostate removed or get radiation therapy? Will I have a better quality of life? Because I know I'm going to have to go through these side effects. Will it extend my life, and will it extend a better quality of life? So there are genes that have been tested, could be tested. This is called GPS. This is Genomic Health genomic assay of these prostate cancers. It's looking at different pathways of how genes are functioning within the prostate. And so this is our multi-gene analysis of the prostate to help predict, if you don't do anything, what is the likelihood that that cancer is going to continue to grow, and what is the likelihood that it's going to spread? And that question is being asked in order to avoid doing surgery or radiation to the prostate. So the example here, an old man, he has a blood test of PSA that's elevated. He's had his prostate biopsies, 12 biopsies of the prostate. 3 of them have cancer in it, and the score is 3+3 or 6. So his clinical stage is T1C based on the staging system. And his life expectancy, because he doesn't have many other medical problems, is 25 years. So the initial doctor, the urologist, said, well, when I look at all these factors, it doesn't look like his risk is all that high. Perhaps I would consider foregoing a surgery or radiation, and let me just watch this patient. And the doc was kind of undecided because it is a very young man, and most urologists tend to take these young men to surgery, but the Gleason score is not that high, and it doesn't sound like there's that much cancer in his prostate. So he has the genomic test called GPS, and it is at a score of 10. That actually puts him in a range of what is called very low risk of developing metastatic cancer. The likelihood, if we removed all of the prostate, is at 83% chance that it's all very low-grade cancer and that will not metastasize. So when patients come to their providers, they've been given a survey that's here that's asked, what do you want your provider to give to you? Do you want to just be told what to do? So this is a survey that was done to show the percent of people surveyed who strongly agree with the statement, I want my provider to, and not surprisingly, number one here is I want my provider to listen to me. And I think what we see is still commonly, for multiple reasons, historically, time constraints, patient desires, that some docs want to just tell people what they need to do. Some patients say, I don't want to participate in choice, just tell me what the best thing is to do. But everybody wants to be heard. The next most common was tell me the full truth about my diagnosis, even if I don't like what you're about to tell me. So a lot of these issues are communication, but then it's like, tell me the risks that occur with each option that you're offering me, how these options may impact my quality of life, and lesser are things like always discuss the option of choosing no test or treatment, but still the majority of these are pretty highly regarded by patients as being important. I love the fact that number one is, I want my doctor just to listen to me. All right, so how about late cancers? So this is where we're heading, and there's multiple companies in this field in what is being called precision medicine. And this, again, is on genomics on the cancer. So, for example, with lung cancers, EGFR is being tested routinely. KRAS is being routinely tested in multiple cancers now, BRAF, PTEN, because there are drugs that will work for these cancers if this abnormality is found within the cancer. So this is just a cartoon showing that you have normal cells, but a mutation occurs in that group of normal cells. That mutated cell now begins to divide, but some of those dividing cells will take on a second mutation. That second mutation cell will begin to take a life of its own. It will create more cells that then they start to add up mutation, and we now have this terminology called mutational burden, how many different mutant genes are sitting within these cancer cells, because it can help be very prognostic for what a patient's outcome is. But we're looking for these mutations to see if there's a drug available that may help them. This is just a kind of a complicated slide to show what happens to cancer cells when they're growing in the body, because the technology is just moving along. So it turns out that our tissues will kind of leak products into the bloodstream that we can pick up and see what those products are. So, for example, in the upper right-hand side is healthy tissue, and it turns out we shed some of that healthy tissue into our bloodstream. We also have blood products that are circulating around there. Up on the upper left-hand corner, we could just go do a biopsy of an area of tumor, but on the bottom left is a liquid biopsy, meaning we're drawing blood and we're seeing if we could see any of these shed cells within the bloodstream. So these technologies are markedly increasing, and there are multiple companies right now where you can do a liquid biopsy. If, for example, you have a lung cancer and we're looking for a specific gene because it might work really well, have a therapy that works really well if you have that gene mutation, we're slowly, I think, going to move away from biopsying the tumors and instead do what's called a liquid biopsy, which is do a blood test, pull out those cancer cells and see whether they've got the gene abnormalities or not. So this is somewhat of a summary on this topic about using genomics for broader cancer care. And I gave you a really high-level view of different products that our company has, but there are many other companies that have similar products or products that are looking genomics in a completely different area. But when we talk about genomics in general, genomics can be helpful to diagnose cancer, and perhaps we will get to the point where we could do liquid biopsy on healthy people and begin to pick up the mutations in blood to know that there's likely a cancer beginning to form somewhere so we could screen earlier. We're definitely using genomics for treatment. We're now using it for monitoring to make sure there's no evidence that the cancer is coming back again. When people have a recurrence of their cancer, we have genomics at that point, and then use the genomics to decide how to manage the cancer. So just go back a little bit on liquid biopsy. Liquid biopsy is not, there's two issues with liquid biopsy. One is you could get circulating tumor cells, so tumor cells that are actually circulating that can be pulled out of the blood, and we can do testing on those. And the other thing that you can do now, which is much more common, is circulating tumor DNA. So not the whole cell, but a byproduct or the genetic information from a cancer cell circulating in the bloodstream. And we now have the technology to be able to pull that out and look at the DNA and see what genetic abnormalities are. So these liquid biopsies are definitely being used for patients with late-stage or metastatic cancer, not to look for cancer, but to knowing that there's cancer there. Rather than doing a lung biopsy or liver biopsy, we can do a liquid biopsy and then test the DNA from those to see whether there's the gene abnormality we're looking for. And eventually we will be moving this down to early-stage cancers as well. So this is just an example of detection of circulating tumor DNA. On the upper, this is the liver has metastases, and we see that in terms of what's happening here, this is looking at blood tests like the CEA, which is a blood test commonly used in colon cancer, and looking at the size of the liver lesions, that's the boxes, and then what's happening with the blood test. So you start to see here the blood test is beginning to rise, even though the scan that you do makes the tumor look smaller, but there's evidence when you look at blood that the cancer is beginning to escape where the therapy is there. On the bottom is a specific gene, KRAS, that we're looking at for melanomas and other cancers. And we can see here that the KRAS is beginning to climb much earlier, so that it's getting us a better information earlier. Even though the CAT scan looks like things are getting better, they're really not getting better, and this cancer is beginning to escape. So we're able to make decisions earlier about switching therapy appropriate for this patient, not waiting for a CAT scan to look worse, but to get much more exact on when we should move to different therapies and then look for a specific mutation to see if we have a specific targeted therapy. The other thing we have is a product that we're going to market this year called ARV7. I know this is all complicated, but the ARV7, it turns out that if men have advanced prostate cancer, and they get exposed to anti-testosterone drugs, which is how we treat prostate cancer. Women's breast cancers tend to grow with estrogen, but men's prostate cancers tend to grow with testosterone. So much of the drugs and therapies we use are to block that testosterone. But it turns out if you block the testosterone for a prolonged period of time, what you start to see is gene mutations in those cancer cells. And with those gene mutations, one of these gene mutations is called ARV7. And ARV7, if it begins to appear, tells us that blocking testosterone is no longer going to work and you need to go to chemotherapy. So on the upper right-hand side here is curves. The blue curve on top are patients with metastatic prostate cancer. We are biopsying the cancer and we see it doesn't have this abnormal gene ARV7, and this is how long the man is going to live. But if he begins to get that mutation, his survival is much, much worse. So now we can do a blood test that picks up whether ARV7 is around, because not only do we understand survival, we're beginning to understand survival might be worse because we're continuing to use the wrong therapy and we need to switch men to chemotherapy. So really complicated, but genomics is a very complicated topic. I'm just trying to give you high-level things to say when we talk about precision medicine. We're talking about really trying to understand what the cancer is telling us. So it's essential to understand and treat underlying individual tumor biology, especially when genomics can play a role in deciding on therapy. We have to strive to identify and eliminate our biases that we have so that we can really open ourselves up for personalized cancer care. We shouldn't make decisions just based on how old a patient is. We shouldn't just make decisions based on how many lymph nodes are involved or how big the cancer is. This cancer has a greater story to tell that can have a significant impact on a patient's longevity and not waste their time on therapies that don't work. Sometimes personal care doesn't involve a treatment. Sometimes personalized stories from that cancer tell us don't treat it. So your interactions with patients as social workers are key to providing optimal care. Patients want to be heard, but I think all of us need to increase our education around where this field is going so that we can all work together in terms of our conversations with patients so that we don't continue to have the biases around cancer, that we allow ourselves to remain open to the science as it's moving along very rapidly underneath us. So these are just some helpful patient resources. Many of you know about these, but I've been asked to show them. So any social worker has an individual relationship with patients, but there are many, many, many more cancer patients than there are social workers. So there are many digital forms of support that patients can go to. One is a My Cancer Coach series, a resource for any newly diagnosed breast cancer patients. It's digital, online, easy to comprehend for patients with newly diagnosed breast cancer, and much easier to understand than this entire talk. There are websites that are available for individual cancers, and then references that people can download or get access to. This was created in partnership with breastcancer.org, Men's Health Network, and Fight Colorectal Cancer. This My Breast Cancer Coach and resources, again, it can have personalized treatment guides based on a patient's pathology report. These are guides. This is not recommendations for specific therapies, but I think it gives people the vocabulary to be able to talk to all of their healthcare providers. And there are helpful tips and videos about how to talk with your healthcare team and how to go through a process of diagnosis and treatment decision making, and then always this issue of healthy living through therapies and when therapies are completed. There's also something called My Prostate Cancer Coach. It's Prostate Cancer 101 information, very simple but complete information, a personalized treatment guide based on the patient's pathology report, something called a prostate cancer roadmap highlighting resources, their patient videos, and then caregiver tips and advice. And coming soon are some caregiver stories. So the website you can see down in the bottom left, there's something called My Colon Cancer Coach at mycoloncancercoach.org. Again, helpful messaging and education for patients, not treatment recommendations, but just giving them the vocabulary and language to help them work through this very difficult medical system. There are also websites called My Breast Cancer Treatment and My Prostate Cancer Treatment, genomic testing information for patients, looking at the role of genomics in early-stage breast cancer. There are patient videos and personal stories. There are issues around insurance coverage, who covers what, and you can see the websites there, mybreastcancertreatment.org or myprostatecancertreatment.org. There's something called Pass It On Until Every Woman, an online community of breast cancer patients, survivors, and caregivers. And you can access these through Facebook, Pinterest, and Google+. And then finally, we have multiple companies that do genomic testing have patient assistance programs. This is just saying that for the company I'm working for, they're committed to facilitating patient access when they're accessing it appropriately to make decisions about their cancer. We offer financial assistance for the uninsured and underinsured, but there's a big team that needs to help up front to get patients to this opportunity. And we have a huge customer service team which helps our patient understand their options, especially around prior authorizations or appeals if their claim for specific testing or therapy is denied. And we have a customer service website and an 866 number for our customer service group. And finally, just contact information around triagecancer.org. So I am going to send it back.
Yeah, thank you very much. That was really interesting. And we have some time for some questions now. And I know that we have received a couple while we were on. One of them is genomic testing covered under health insurance? And if you have HMO, will they even authorize it?
So again, there's a difference between genetic testing and genomic testing. So it depends on what the test is and why it's being ordered. So if you're ordering a test in the wrong cancer, that's not going to get paid for. But these genomic tests, certainly ones I talked about, are predominantly covered by the majority of insurances. So what we always do when we have a new test is we get Medicare coverage first, and then when we get Medicare coverage, then the other insurance companies tend to fall behind and do cover the same. So all of our genomic tests tend to be covered. Certainly the breast cancer test is covered. HMOs cover the majority of the genomic tests that I showed today.
And are we at a point now where our oncologists will automatically recommend genomic testing?
Well, it's
or is this something we should bring up?
Well, for early breast cancer in the appropriate time, there's at least 40% of the population of women with early breast cancer who could use genomic testing to make chemotherapy decisions where it's not being ordered. Either because the doctor's already decided that they think the woman needs chemotherapy, with what I think are misguided reasoning, not using all the tools that we have available to us. Certainly you don't want to order a test if someone says, I refuse under every circumstance to take chemotherapy. Or some women will say, you're going to have to prove to me I need chemotherapy, and this tests are very helpful in that circumstance. But we think that no more than 60% of women with early breast cancer in this country are being offered these tests appropriately, and I think there's a lot of research to show that. So I think even if these questions to you seem dumb, like I practiced for 31 years, and people would bring in stuff and say, why aren't you doing this test? And I would say, because for this cancer, you don't have any chance that you could have that gene abnormality. It doesn't help to test for it. If your doctor puts you off and we're not going to do it, I know what's best for you, that's time to move on. But there are some great resources online to educate yourself if you're diagnosed with a cancer about what your options are.
Okay, great. Another question we got was one about cost. So considering that the CAR T therapy option with a cost of $700,000 per injection, where are we going with the affordability of this testing?
Isn't that great? So, what happens usually when you get insurance coverage is you have to prove that the cost it looked at for life years saved. And this is sort of a standard measure of assessing cost against how many years of life are saved as a result with a specific cost. Like the ability to get dialysis was based on that. So the use of insulin for diabetics is based on this. What is the cost per year to someone to give them an extra life year? And that's how insurers and guideline groups use these costs to help understand and decide whether these things will get covered by insurance. As things become more common, costs will come down, but a lot of these expensive tests, so one thing you have here is not a test but a therapy, right? And you don't want to use a therapy that's extremely expensive unless you have a test to show that therapy is going to work. And so you got to have genomics there first so that you can target someone towards a specific therapy. For example, the Archetype test for early breast cancer runs around $3,800. One cycle of chemotherapy is well over $3,800. So, if you can avoid chemotherapy in 80% of the women, which is essentially what our test does for women with early breast cancer, the money saved is enormous, but you have to prove that to the federal government and insurers before drugs will get approved at that cost.
Okay. We got one more question we're going to try to squeeze in here. It's kind of a very specific question, so hold on. Certain inherited cancer genes are showing an association with more aggressive prostate cancer phenotypes. I didn't see these genes on the assay. Were these germline mutations looked at and potentially crossed with an assay to see if a particular signature suggests an underlying germline mutation in one of the inherited cancer genes, or is it believed that the aggressiveness of the prostate cancer in inherited cancer syndromes are due to a separate pathway and may be included on assays later?
So, so you have the genetics, so you're doing the genetics to show that it's an inherited cancer. The issue is that, for example, men with the BRCA1 gene who have a higher risk of prostate cancer, you may say that not only do they have a higher risk of cancer, but they may have a higher risk of a worse cancer. But not all men do. So yes, the men who get prostate cancer with that gene as a group tend to have a worse cancer, but not everybody does. And those cancers do get looked at when they create the genetic panels. So the creation of a cancer, for the most part, doesn't seem to necessarily relate to the genes that drive the cancer once the cancer begins to mutate and grow. They tend to be really separate genes, but the companies that have created the gene profiles to help understand best therapies, or if there's a mutation that will predict for a certain kind of therapy, have gone back and looked at all of the inherited genes and added them to the panel to see if they were informative, and to this point they are not.
Okay. Doctors, we've come to 1 o'clock and we need to end this now. I want to thank you so much. This certainly gave us all a lot of information to think about. And I kind of wish we had this when I was going through my ordeal.
Yeah,
so anyway,
right, exactly.
I want to give you one more reminder about the continuing education units. If you are looking for continuing education units, you need to fill out the survey that I'm going to send you a link to right as we conclude this. So get that in to me within 5 days. And remember that the email address you put on that will be the email address I will email the certificate to you. Okay, well, thank you all very much for joining us today, and have a great day.
Thank you.